Hello, everybody, and welcome to this lecture on iron studies and the related anemias. So first of all, it's important that we understand why iron is related to anemia and our RBC production. So this here is a diagram of heme molecule, the heme ring, and as we can see, the center ion here is iron. So iron is a crucial part of the heme ring, and more importantly, iron is actually what binds to the oxygen in heme. So without iron, you're not going to bind heme, you're not going to bind oxygen, pardon me. And if you think about it in heme production, like go back to your basic chemistry with reactants and products. Iron is a reactant in heme production. So less iron you have, it's not going to push that reaction towards the product side, right? Thus, less iron equals less heme, generally speaking. Okay. Now let's quickly talk about the iron metabolism as well, because this is really important for step one. We start over here. This is the gut brush border. Iron is primarily absorbed in the small intestine, especially the duodenum and jejunum. And this is the lumen. So you eat food, and there's food iron, and some of it is already in the heme form, especially in your red meats. You'll absorb heme iron. And then your non-heme iron gets redox reaction to the 2+ state, and that's where it can really be absorbed. And this is one of the transporters you're going to want to memorize for step one, which is the DMT1 transporter. Helps the uptake of iron into the mucosal cell, not directly into the bloodstream yet, but into the cell. Okay, and then once we're in the cell here, you have a second transporter, the ferroportin-1 transporter on the other side of the brush border, and that actually transports the iron from the cell into the tissues and bloodstream. Okay, and you can see here that iron is then brought back into the bloodstream, and that's where it can begin the process of being incorporated into heme when it's brought into the reticuloendothelial system. Okay, we're going to talk about hepcidin a little later when we talk about anemia, chronic disease, so don't worry about that right now. But for this slide in metabolism, make sure, I would say, memorize the name, the DMT1 and the ferroportin-1 transporters. Those are important for step one. They like to test on those. Okay, so this is a slide that if you watch my anemia lectures, it's the same exact slide, just to go over the basics of anemia in general. It's a deficiency of red blood cells or hemoglobin. As you can see, hemoglobin is different for men and women. And you're going to want to check with your actual lab, because each lab has different values, but generally speaking, it's around 12 or 13 as the lower limit. And obviously on the test, they'll usually give you that value. General symptoms of anemia: fatigue, dizziness, lightheadedness, pallor, shortness of breath. Generally speaking, these are the same type of symptoms as hypoxia, because that's in a different type of, in a smaller scale, anemia is hypoxia because it's a deficiency of oxygen carrying capability in the blood. So when it comes to iron and the iron-related anemias, there's a few values we care about. First of all is the MCV. Generally speaking, an MCV in iron-related anemias is less than 80, or it's a microcytic anemia. And if you're wondering why I'm saying iron-related anemias, it's because I'm really talking about multiple types, which is iron deficiency, anemia, chronic disease, and even something like Plummer-Vinson. These are all related to iron. The RDW is an interesting one that people don't usually think about, which stands for the red cell distribution width. Basically, what the RDW means is the range of sizes of the RBCs. It's reported as a percent. You can think of it in statistical terms as the standard deviation of the width of a red cell. So how do we interpret this? Well, the larger it is, it means that there's a larger deviation or a larger range of the size of the red cells, and that generally leads us to think that there could be something wrong with the production or with the maintenance of the red cells. RDW is usually elevated in certain types of anemia related to iron. And then here, these four at the bottom, these are what classically make up your iron study. So if you order an iron panel, it's usually going to be these four altogether. And first you have the serum iron. The serum iron is basically the amount of free iron in the bloodstream, okay, available to use. Ferritin, on the other hand, is storage iron. This is the amount of iron, or an estimate of the iron in the tissues that is not freely available to be used for heme. Okay, and the distinction between these two is going to be evident when we talk about iron deficiency anemia versus anemia of chronic disease. Third, we have the TIBC, which stands for total iron binding capacity, and that's kind of the same. It's really a moniker for transferrin. Transferrin is a molecule that is used to transport iron. So transferrin transport. It does that by binding to iron. And so your total iron binding capacity basically is a measure of how much transferrin you have, because it's talking about how much room there is for iron to bind. And what does it bind to? It binds to transferrin. And then the percent saturation is basically a combination of all of these. Percent saturation refers to the percent of transferrin that is currently bound. Okay, the percent of transferrin that is currently bound to iron. And so the normal for percent saturation is usually around 30%. Okay, so all of your transferrin under normal conditions is not bound. In fact, the majority of it is unbound. So that's how you can interpret these. So the three iron-related anemias that we'll talk about are iron deficiency anemia, which is by far the most common anemia, anemia of chronic disease, which is also referred to as anemia of inflammation, and then I'll talk briefly about something called Plummer-Vinson Syndrome, which is a form of iron deficiency anemia. So IDA, or iron deficiency anemia, the pathophys here is, well, you just have decreased free, bound, and storage iron. All forms of iron is low in iron deficiency anemia. How does it happen? Well, one common cause is actually chronic blood loss. Not acute blood loss, because that is just acute blood loss. That's kind of an emergency. But chronic slow bleed. So this happens a lot of times with women who have heavy menstrual periods. That can lead to slow but significant blood loss over time. Also, GI bleeds are a very common cause. So if you have somebody who's iron deficient anemia and you can't really find another cause, occasionally you'll start to think, is there a GI bleed going on that we need to worry about? And in fact, it's also oftentimes thought of as a sign of malignancy, possibly if you're able to isolate that GI bleed. Malnutrition, this isn't too common because there's iron in a lot of things, but somebody who's malnourished, or if a heavy alcoholic who's not really eating right, malnutrition can be a cause. Decreased absorption, different conditions or different gut biomes can cause increased or especially decreased absorption in the small intestine. And then weight loss surgery, things like Roux-en-Y and gastric sleeve lower the surface area that could be used for absorption. So weight loss surgery is it causes an iron deficiency through decreased absorption. Okay. On the smear and the pathology, you're going to see microcytic hypochromic RBCs, meaning small and pale. So these are very pale. You can see a lot of central pallor here. And the reason that this arrow is pointing towards this, what is probably a lymphocyte, is that normally your RBC should be the size of the nucleus of a lymphocyte. Okay, so that's the nucleus right there. And you can see that these RBCs are fairly smaller than the nuclei, so that shows that it's microcytic. For the test, you won't need to really say from a slide, just looking at a slide, that a cell is microcytic, but you should be able to look at this and note that it's hypochromic, and oftentimes hypochromia goes with microcytosis. Let's talk a little bit more about IDA. The symptoms are basically your usual anemia symptoms, the ones we talked about earlier, the pallor, the fatigue, the lightheadedness. And then the two kind of unique to iron deficiency anemia is pica. Pica is basically just the craving for eating things that aren't necessarily food. And the biological reasoning for this is the body knows it's iron deficient, and it knows that it gets iron through the diet, so it starts craving things. So the classic vignette you'll kind of see on the boards as far as pica and IDA is somebody with iron deficiency signs, but that also has been eating a lot of ice chips lately. Ice chips, as we know, have no nutritional value, but that's a sign of pica in these cases. and also koilonychia. This is, not as common. It takes a long time for this to happen, but koilonychia is spoon-shaped nails, and that's what this picture is right here. You can see that these nails kind of really have that scooped out appearance, and this is kind of an exaggeration, this picture, but this is the general appearance of koilonychia. And now, perhaps the most important part is interpreting the labs. So as we mentioned, early on, iron deficiency actually starts out as a normocytic anemia, a normal MCV, and later on it develops into microcytic. And as we said, the RDW is elevated. But how do we interpret the iron labs? Well, as we said, iron deficiency anemia is a deficiency in storage and free iron. So our serum iron, which is our free iron for the purposes of this lecture, is low. And that's kind of the obvious. If you're iron deficient, you have low free serum iron. Okay, and I'm going to talk about ferritin next. Ferritin is the storage iron, right? We said iron deficiency anemia, you're deficient in serum and storage iron, so that's also low. Transferrin, or the TIBC, remember what we said transferrin is. Transferrin is a measure of how much transferrin is in the blood, which means the molecule that attaches and binds to iron to transport it. Well, if you don't have very much serum iron, you're going to have a lot of leftover transferrin in the blood because all the transferrin is free and not bound because there's nothing for it to bind to. There's not that much iron left. Okay? And similarly, the TIBC, or the total iron binding capacity, you have more iron binding capacity because you have less iron, right? So think of the transferrin of the TIBC always as a result of your serum and ferritin, okay? The transferrin saturation, or the percent saturation, is going to be low as well for the similar reasons. We have low iron, then less of the transferrin is going to be bound to iron because there's just not that very much iron, which means the actual amount of transferrin that is saturated is lower. It's not very much of it is in the bound state, so that's what makes it low. Okay. Moving on to anemia of chronic disease, otherwise known as anemia of inflammation. So, there's a lot of pathophys here, but, talking about what you need to know for the test. Inflammatory state leads to an upregulation of this molecule called hepcidin, and this is what you must absolutely know under all circumstances. Do not forget the name of this. Hepcidin. They love to test hepcidin on USMLE step 1. Okay, so I'm going to move over to this flow chart here. You have a chronic inflammatory process, a chronic disease. This leads to your upregulation of your inflammatory cytokines. That's kind of outside of this lecture, but things like IL-6, which are your acute phase reactants, IL-1, interleukin-1, which is your fever kind of mediator. And we're going to focus on this side of the flow chart here, not so much the EPO. But when you have this upregulation, you upregulate hepcidin, right? Remember, don't forget hepcidin. And now I'm going to bring you back here. When you have hepcidin, what does hepcidin do? It decreases your gut iron uptake. Decreases the uptake, and it also decreases tissue and macrophage release of iron. So it's doing two things. It's preventing you from uptaking it, and then the iron you have, it's holding it in storage form. It's not allowing your cells and tissues to release the iron into the blood. Okay, so this comes down to hypocytiranemia, which means low amounts of serum iron, free iron in the blood, and increased retention in the tissues. MPS is basically your macrophages and your reticuloendothelial system. Okay, so you have increased retention in the tissues, decreased free iron, thus giving you anemia of chronic disease. Another interesting point is in states of active infection, you can also see an anemia of chronic disease type picture, and the thought process behind that is bacteria and pathogens use iron in their metabolism to survive, so the body puts you into this anemia of chronic disease state and upregulates hepcidin to prevent those pathogens from using the iron and proliferating. Okay, so the main causes here in anemia of chronic disease generally is your rheumatologic and autoimmune. Those are a huge cause. Your lupus, your rheumatoid arthritis, those types of things. Also cancer, malignancies, and like I just said, those infections and chronic infections too. So how do we diagnose and see it? Well, first of all, I put this picture in because this might be, a lot of times, is the classic type of patient you'll see who has anemia of chronic disease. They may otherwise look healthy. Usually it's elderly, oftentimes female, and I had her kind of rubbing her joints because she has rheumatoid arthritis, and that's a very common picture to see in anemia of chronic disease. So on your labs, it's going to be normocytic or microcytic, a normal or low MCV, normal or elevated RDW, as all our anemias are. And I included the iron deficiency in here so that you can compare. So, like we said, the role in iron anemia of chronic disease is the hepcidin causes decreased absorption and decreased release from tissues. So that means you're going to have low serum, just like in iron deficiency. So you have low serum iron, because you're not absorbing and you're not releasing it. Next thing you should look at is the ferritin. This is what's going to help you distinguish between iron deficiency and anemia of chronic disease. Ferritin in chronic disease is high. Why? Because remember I said hepcidin prevents iron from being released from the tissues and macrophages. When it's in the tissues and macrophages, it is ferritin. It is storage form iron. So you're getting this buildup of iron in the tissues, therefore your storage iron is high, therefore your ferritin is high. This is a big indicator of anemia of chronic disease. The transferrin, or TIBC, is a little confusing here. It's actually going to be read as decreased, and that's kind of another evolutionary thing where the body is down-regulating transferrin production because it does not want the pathogen, especially in cases of infection, to use it to their advantage. You're not really going to be using transferrin or the TIBC on an exam or even in real life to diagnose chronic disease particularly. It's really going to be the contrast of high ferritin, low serum is going to be what gives away anemia of chronic disease. And your transferrin saturation or your percent saturation, this will make sense to you. It's going to be low because, well, you just have very little serum iron. So your transferrin is not going to be in the bound state. It's going to be free. So you have a lot of room for it to bind. Therefore, you have high transferrin saturation or percent saturation. Finally, the last one is Plummer-Vinson Syndrome. This is fairly quick, but it's basically has this classic triad, which you should try and remember, which is iron deficiency anemia, esophageal webbing, and dysphagia, which the dysphagia is essentially secondary to the esophageal webbing. But iron deficiency anemia, esophageal webbing, dysphagia. And this is what, if you did a barium swallow test, this is what you'll see. And you can see all these areas here where you have these narrowings is esophageal webs, okay? And if you you can look up pictures of an endoscopy, you'll see the webbing as well. The labs and symptoms are all exactly the same as iron deficiency anemia because that's what it's based on. Okay. So thank you for listening. I hope this was helpful. Just remember those biggest things is the serum versus the ferritin. Those will help you distinguish between iron deficiency anemia and anemia of chronic disease. Don't forget hepcidin, and don't forget the DMT1 as well as the ferroportin transporter. And I think you will be doing well on your iron questions on the test. Thank you.